Prostate cancer is the most common cancer in men only, which affects all race types. However, death due to prostate cancer is relatively low, provided that it is detected and treated before it has metastasized. Metastasis is one of the hallmark features of cancer development, characterized by the dissemination of cancer cells from the primary site to other tissues via the vascular system. Since metastasis is a common hallmark amongst all cancers, we believe inhibiting this hallmark would be an effective strategy in increasing the 5-year survival rate of cancers, especially prostate cancer, where it will remain close to 100%. Although the likely cause of death for prostate cancer is clearly established, there remains poor treatment which specifically targets metastasis of prostate cancer. Based on these statistical data and limited therapy in treating prostate cancer, our team is proposing a novel anti-metastatic cancer drug by using a synthetically modified snake venom found in MichaelChau. But in order to understand how this toxin can inhibit metastasis, we need to first understand the physiological cascade that occurs during metastasis.
Metastatic cells metastasize to other tissues via the vascular system. This includes both the lymphatic and blood vessels. However, in order to survive in these vessels, they must activate platelet recruitment. This involves platelets surrounding the metastatic cells, which act as a buffer against the shear force of blood flow and escape natural killer cells detection. Without platelets attachment, metastatic cells will apoptose. The pathway for platelet activation and recruitment requires secretion of mediators from metastatic cells. One of the crucial mediators is adenosine diphosphate. Secreted ADP from metastatic cells bind to P2Y12 receptors, which are expressed on platelets. This ligand receptor interaction initiates the GPCR cascade, resulting in activation of G-alpha I protein and subsequently inhibition of adenylyl cyclase. This causes a reduction in cyclic AMP and an increase in dephosphorylated vasodilator stimulated phosphoprotein. Ultimately, higher levels of VASP activate GP2B or 3A receptors, which are responsible for initiating and stabilizing platelet aggregation. However, when KT6.9 is administered, this pathway is inhibited. KT6.9 acts as a competitive antagonist by competing with ADP for the same binding site on P2Y12 receptors. This reduces the binding probability of ADP to P2Y12 receptors, resulting in decreased activation of the GPCR cascade, and subsequent downstream effects required for platelet activation. Downregulation of the GPCR cascade involves decreased activation of G-alpha I protein and decreased inhibition of adenylyl cyclase. Ultimately, cyclic AMP's level will return to normal, causing increased phosphorylation of VASP. Phosphorylated VASP is unable to activate GP2B or 3A receptors, resulting in decreased activation of platelet aggregation. If platelet activation is inhibited, then metastatic cells would become naked in the vascular system. Without platelets acting as a protective barrier for metastatic cells, they will die rapidly due to destruction by immune cells and mechanical stress from blood flow.
KT6.9 is a venom that is naturally toxic to humans. Therefore, purification processes are required to eliminate potential poisoning side effects while preserving the anti-metastatic properties of the venom. Our mode of delivery will be via intravenous injections, since metastatic cells can only travel in the vascular system. The chemical structure of KT6.9 is also small enough to easily flow through capillaries and at the same time remain impermeable to the endothelial wall to prevent leakage into the extracellular matrix. Moreover, the outer hydrophilic structure of the venom will ensure it travels in the blood without difficulty. However, appropriate testing will be required to address problems such as drug localization and drug specificity before this can become an accessible therapy. We suspect that inhibition of the P2Y12 receptor pathway will be compensated by upregulation of an alternative pathway such as GQ-PLC calcium pathway, which can also activate platelet aggregation. Therefore, to counter this, a combination of therapy may be required to target multiple platelet recruitment pathways. Platelet aggregation is a critical step in normal homeostasis. Therefore, KT6.9 must also have high specificity to cancer-induced platelet aggregation only, to avoid interfering with platelet recruitment required for other physiological processes such as wound healing and blood clot formation. KT6.9 must also be localized at the vascular system to prevent binding with other tissues, which may decrease the efficacy of the venom due to lower concentrations of KT6.9. We must also determine therapeutic dose and frequency of administration, ideally restricting the need for injection to once a week. These limitations will be investigated during preclinical trials by testing on transgenic adenocarcinoma mouse prostate models, also known as TRAMP models.
If you choose to invest, we plan to start addressing these limitations so that this therapy can become the clinical gold standard for prostate cancer.